Has your child ever had a vision screening? Were you convinced afterwards that their vision was fine? Did you know that with the current system of vision screening in Australia, particularly in Queensland, we could expect that 40 to 50% of children with vision problems will remain undiagnosed compared to screening with the modified clinical technique? So today we'd like to discuss what happens during a comprehensive eye examination and how that differs from a school screening. So I'm Tom from Eye Care Eyewear, and trying to bring an evidence-based perspective to behavioural optometry. By way of background, I've been practicing optometry since 2001. My practice holds over 25,000 individual patient records, and I was fortunate enough to be accepted as a fellow for the Australasian College of Behavioural Optometrists. Today, joining me again, thank you very much, is Sarah Kay of Artios Optometry. So I'm just going to bring Sarah in now so we can see Sarah. How are you, Sarah? Now,
Hi, Tom.
Now, Sarah became a fellow of the Australian College of Behavioural Optometrists in 2007, and she served on the ACBO examination board, as well as being a lecturer and clinical supervisor for the 4th and 5th year optometry students at the Queensland University of Technology, where we both studied together. She's also, as I mentioned, the principal optometrist of Artios Optometry, which is an independent practice in Brisbane, and they provide an optometric experience that empowers their patients and increases their well-being by creating a plan to restore vision to its best. I love that, Sarah. That sounds great. So what are we going to do today? We're going to talk about, so like, let's say for instance your child had a school screening past, so they can see, right? Their vision's fine?
I'm assuming they've had their eyes tested, so they're fine. That gives us a tick. We don't worry about it anymore. Is that right?
Well, that's the thing, Sarah, isn't it? Not necessarily.
Right.
I've got a lot to say about school screenings. Now, can you remember why I've got so much to say about school screenings, Sarah?
Now, let's see. I think you submitted, I think that was part of your fellowship thesis. Would that be right?
Exactly.
You may have done a research project on that.
Research project was called The Inclusion of Parent and Teacher Questionnaires and Visual Perceptual Testing in School-Based Vision Screenings. Bit of a mouthful, but basically what we're trying to do is include some extra things in vision screenings. So if anyone's keen for a copy of this, I'm happy to share it at the end as well. And
look, I have read it from cover to cover.
Yeah.
It's actually really easy to read, and I think there was a lot of great information in it, and it did modify how I did some of my screenings after I read it. So
awesome.
Thank you.
Oh, that's all right. That's really, really good. Thank you for the endorsement. So one of the little things I found from that study, which was really interesting, I'll share it with you now, was from a study in 1994, an American study entitled "The Primary Cause of Failure in Beginning Readers." And what it concluded is that visual factors are the primary cause of early reading failure, and that most conventional American school screenings are inadequate. So I sort of maybe of the opinion that there's some issues with the brevity of the tests, the number of tests that's conducted in some of our school screeners, and is it maybe possible that our school screenings are suffering the same fate? In my opinion, obviously, it's super important that kids actually have a comprehensive eye examination as opposed to a school screening.
Yeah.
Now, if anyone's got any questions about this too, like please don't hesitate to give a comment, and we'll hopefully be able to answer them as we go or later as well.
Yeah. So it's fair to say that the screenings that you're referring to are the screenings that are done in Queensland, and it's the screener that's done usually in prep. Is that right?
Yeah, well, I mean, to be honest, we haven't really been given that much detail with it. From what I understand, they have got a cycle where the school nurses go and do these screeners, and the school nurses will then refer on to an optometrist, of which there's a list that they've selected, and then the onus is on the optometrist to do the extra test and apply any sort of interventions, and then report back to the school screening, the nurses. And look, I think we've got to say from the outset too that we really need to acknowledge the hard work that these guys do for this as well, because there is some wonderful results that come out of school screening, and I'm sure, Sarah, you've seen some patients that have been referred that you've found to have major problems, and you've instigated some life-changing interventions.
That's right, and much as you've experienced, potentially they may have never been picked up.
That's right.
So I completely agree. It's certainly a worthwhile service that's provided. It's a government service that they do.
Yep.
By going in and doing that.
State funded.
Yeah, that's right. So yeah, as far as Queensland goes, like this is only recent. It didn't exist a few years ago. So we appreciate that it exists, and we're thankful that it exists. There's just a but. But.
So let's dive into that. I'm going to bring up on the screen now. I'm going to share my screen, and I'm going to bring up some details of the school screening information from the primary school nurse health readiness program. And so this is a program that's administered here in Queensland. And so basically what they utilise is two tools for their screening. The first one is testing visual acuity with a letter chart. Sounds very reasonable. And the second,
that's just the basic test of sight.
Yep, yeah, it's called the PAR test. It's at 4 meters. And the second one they're going to use is what they call the Welsh Allen Spot Vision Screener. So I actually happen to have one of these screeners, and like I've got to admit, it's a pretty impressive piece of kit. It looks really, really good. I'm really happy with it. But again, I'm not 100% sure with the accuracy that I find with this machine. So I'm just going to switch back to my screen now, Sarah.
Yeah.
So everybody can see this. But I had a patient this morning that I tested, and he was identified by the screening and came to see me. And he's in, this is optometry speak, but he's in a pair of plus 450s and a pair of plus 5. So it's quite a high prescription.
Yeah.
And he's happy as, very, very happy young man, going to do really well this year for year 1. So I'm really excited about that. However, when I did the spot screener for him today, you can see that there's a lot less power that's been identified there. And I've also managed to do another autorefraction from my other autorefractor next to it, and the autorefraction readings are significantly higher. So that was a little bit concerning for me, to be honest, that they're using this device that seems to, in some cases, underestimate prescriptions.
Yeah. I think it's fair to say, the word screener is the key word there. It's a ballpark idea of what's happening. It's not detailed and comprehensive and exact.
Yeah, and the other thing that I found interesting too, Sarah, is that I did a little bit of digging about and some research about different places that do different sort of screenings. And remember last week we talked about the fact that there's places in America where where you need to have an eye test beforehand.
Yes.
Well, I'll go back and clarify that. That was actually the state of Massachusetts, and what they sort of said was that upon entering kindergarten, within 30 days of start of school, a parent or guardian of each child shall present a school health personnel certificate with their child, and the whole idea is that it'll have like a pass-fail, and that's all done by obviously state-sanctioned, within the department, not necessarily by optometrists. Right. And if the child was to fail, then they would then go on to see an optometrist or an ophthalmologist, and then go down the path of some sort of intervention. But another interesting thing I found about the Massachusetts is that they also have the distance linear visual acuity screening test, so they're checking people's ability to see. Yeah. And they have an ocular alignment and stereopsis assessment. Now, this is something that we do all the time. I mean, it's just one of those tests which is wonderful at determining just how well your eyes work together. And I think we should touch on this a little bit more when we come to talking about our the sort of tests that we operate in a comprehensive examination. But that was interesting that they included that. But most interesting to me was that they said that they've got, with respect to the use of machines, the department does not recommend the use of machines when screening preschoolers and kindergarten-aged children. So I thought it was really interesting that we have a device that's being used in Queensland that's, in the state of Queensland, which is about 5 million people, and in the state of Massachusetts, where there's 7 million people, they've specifically said that they don't want to use this particular device.
Yeah. So why do you think they've advised that?
Well, I think it's got to do with accuracy. And this actually leads me back. We'll just flick back to the screen that came from the hospital's, here it is, the primary school nurse health screening program. And they actually stay in the information that provided to optometrists or to health information to health professionals, that 6.1% of children screened by this system are referred to eye health professionals for further assessment. Now, Sarah, we all know the statistics, and we're always, it's 1 in 5. Like, that's what we've been told. 20% of people are going to have a vision problem. So there's a fair few children that are slipping through the cracks with this particular screening protocol.
Yes.
And then
Yeah,
the next,
that's a bit concerning.
the next statistic was in 2018. This is what from their study, from their the document. 68% of children referred by the system were found to have a visual abnormality. So that's 68% of people referred. So that means that there's 32% which could be regarded as a false positive.
Yeah.
And false positives, I suppose, that's, they're better than false negatives, which I was going to talk about in a minute too. But that's a lot of people being referred that don't have a problem.
Yes. Yes. Yeah, and I think you're right. The accuracy with the instruments, I think it's harder because they're such young children. And to get a good reading on these instruments, the children really need to be able to hold their attention very steady for, it's a few seconds, which might seem like nothing, but to a preppy who's in a noisy, distractible environment, or if they're a bit unsure of what to do, I think that's why the accuracy can slip.
Yeah.
Just because it's a fairly high demand task for a small child.
And when you think about it too, like if we were to do another test like a random stereo acuity, which is the testing how well your eyes work together, that really shouldn't take a whole lot more time than doing this spot screener. Like they would be fairly similar, I would say, in terms of the time. I mean, obviously not automated, but similar in terms of the time.
That's what I was going to say. What do you think should be there instead? Doing that?
Well, let's get to that in a minute, because that's the whole point of that whole study that I did.
About that.
Yeah, that's okay. Look, I said the other thing I wanted to talk about too is I'll never forget this day because I'm a little bit upset about it. But basically, and this was a little while ago, maybe say 6 or 7 years ago, but I had a health nurse that came in to see me with a letter chart and asked me how to use the letter chart, like what distance is meant to be, and I commended her efforts. Like, thank you for going and doing this. I really appreciate it. But on the same token, I'm thinking, oh my goodness, like this person is charged with that responsibility to pick up these problems, and she didn't have that as well. Anyway, so I'm assuming it was just a one-off and it will never happen again. But that was a day that I will never forget. Yeah.
Yeah. Okay.
Yeah. I mean,
it doesn't leave you with a lot of confidence.
Yeah. Well.
Yeah.
So false negatives. That's the other thing I want to talk about too. So this is a great concern of mine. So false negatives means that kids who have a problem, they're not picked up and they slip through the cracks. Have you had an experience with this before?
Yes, most certainly. When we ask parents on our questionnaires, has your child had their eyes tested before? And a lot of parents will just say yes through the school screening and everything was fine. And then we start testing and all sorts of issues will come out. So yes, that's what I've experienced. Yeah,
and it's a tragedy, or it can be, because you might have a child that turns up in their sort of teenage years and they have all sorts of visual maladaptations, astigmatism, myopia, and those sort of things.
Yeah.
But they had a screening test when they were in prep or year one, and it was fine. So I mean.
Yeah, and that's a good point. I think that's a really good point to raise. Just that one test back then doesn't give you a clear runway for the rest of your life.
Exactly.
If anything, that screener should be done every 12 months.
Yeah.
To try and pick up what's happening, because the visual system changes over that time. So you're right. I think that's a really good point to highlight.
Yeah, stress demands change throughout different years, and different kids are applying themselves and learning at different stages. So yeah, it's natural for them to have some differences throughout.
Yes. Yeah, good point.
So look, I thought the other thing we should talk about now is like what happens during a comprehensive eye examination, because some people may not have a concept as exactly what that involves. And I think it's worth mentioning that every single optometrist has a different protocol that they've sort of developed over the years. And I suppose the way that I think about it is that in a developmental optometric setting, I'll have a number of different sort of targeted assessments, and I'm trying to formulate a hypothesis. And a lot of this has come from the case history to start with, from which I can then create a clinical profile which then fits all the signs and symptoms that the patients have described. And then I can work out the management strategy from there.
Yeah.
So do you want to share what would be a standard consultation for you, or do you want me to just dive in and tell you the ones that I would, like what a normal battery test would be for me?
I want to hear your list, and then I'll add anything that's missing.
Okay, fair enough.
Yeah, let's go back to fellowship exam.
Yeah. So first thing is, so if somebody comes in to see us, we will, sometimes we start with a questionnaire, but not necessarily, but sometimes a questionnaire. Questionnaires are great because particularly for kids that might have some special needs or and have some issues with the concentration, you can eliminate that sort of first 5 minutes of the test where you can actually start to hone in on the child, but without them sitting there while you're asking the parents some questions. So that's really good. The next thing we'll move into would be pre-testing. So I've got a separate pre-testing area which includes an autorefraction, tonometry testing, keratometry, and photos and OCT. And I try and do all those on children because it's some great information to have. I might not necessarily use all those pieces of information for my clinical decision making, but it's there. We've got it, and we're good to go. Then we jump into case history. So we're going to ask all these sort of important questions, the targeted questions towards the things that the patient might have a problem with. Then
I think they're the basic questions like, yes, can you see? But it's all of these extra things that people might not think about, and you're taking the time to make sure that that's not an issue. Like when they change focus from the board, does it go clear straight away? It's these little details that give us a lot of information, and it takes time to ask those extra questions.
Yeah.
So I think that's the difference between a comprehensive consultation that investigates lots of different areas as opposed to a screening. Very comprehensive.
Definitely, and I think your case history will also change sometimes depending on the questions that have preceded as well. Like you might sort of go down a different avenue of questioning to sort of work out what your proposed thought process in terms of what the problem is. So that's how I approach it. Now, the next question that I ask the patient is probably one that I really like. It's probably one of the most important ones, and it is cover your left eye. Now, what happens when you say that, Sarah? When you say cover your left eye? Yeah.
This one? This one? This one? Is that what happens?
Yeah, all the time. It's telling me a lot of information, obviously, isn't it? I mean, that sort of development of your ability to know your left and your right is quite a critical skill when it comes to so many facets of your visual development. So, look, I like that one. And then obviously I'm going to check for people's visual acuity. So we obviously got a chart, electronic chart that we use.
Checking their sight, yep.
Preliminary tests, which I classify as when we cover one eye and then cover the other eye and see where they want to see it when they're not being used. And what we call near field of convergence, we sort of bring an object really close and see how well the person can converge. We might do a pupil assessment where we shine a light into their eyes to see if the pupil reacts in a normal sort of way. An eye movement assessment, which oftentimes I just use a wolf wand, which is one of these special wands that I wave in front of people.
Yep.
A colour vision test, so that's checking with the Ishihara. That's a test to see if they can perceive problems with colour, if they have problems with the colour. And then a quick confrontation as well, so just make sure there's no issues with their peripheral field, all the things that you'd expect in a preliminary sort of examination. And then we dive into refraction. So this can be pretty challenging to do for young kids, but there's lots of little tricks that we have to sort of try and work out what the prescription is. Some of these would involve, Sarah will know the term of binocular blowback, or maybe, for instance, cycloplegic refraction. So the ones that we can work out how long-sighted, because most children are a little bit long-sighted. Then we move into the visual efficiency tests. So these are where we check to see how well the eyes work together as a team. So things like 4 areas, what we call ACNA ratios, how well you can focus and accommodate, how well you can hold your eyes together in fusional reserves. Then I like to do my ocular health assessment as well, which, mind you, has probably partly been done by the scans that we did previously.
Yeah.
Then I just jump straight into my visual information processing assessments. So this is where we check to see how well the eyes and the brain work together. And I think there's some really great ones. We can target those particular type of tests depending on the child's age, and they're all age matched, so we can give the parents a really good indication of how they're performing compared to other kids their own age. And look, that's pretty much, that pulls me up. So Sarah, is there anything else that you can think of that you like to include?
No, I think you've done pretty well there. Did you mention, so you'd be checking their depth perception? Was that in your preliminaries? When did
Preliminary
you do that
tests would be, yes. Actually, I didn't write that down, but I definitely would be using the Randot Stereo
I thought
Acuity.
you would be, yeah. Yeah, and that's right. So it takes a lot of time to go through all of those tests. But yeah, that's pretty much my battery of tests as well.
Yeah, look,
I did slightly different order, but yeah.
But I think that we deserve to give the patients that as well, because that's really what we need to create the clinical picture to decide what is the most appropriate for the patient.
Yeah, absolutely, absolutely. And sometimes there's a few ways of doing the same test. Like when you said, you're checking their accommodation or their focusing ability. We can do it using, behind the phoropter, behind the instruments, or we can do it using torches and lights. We can measure it doing lenses. So sometimes you might need to do all three different ways for checking someone's focusing. So we can, really get a very, very big, detailed picture of what's happening with somebody's system. Much, much more information than you're going to get from a screening.
Yeah, and that's the thing, like you've sort of alluded to this, but like some kids will concentrate differently at different points in the examination, and that's all valuable information too. So we might go back and repeat a test because we think we did quite well at that, but I'm thinking you probably shouldn't do quite as well as that at that. And we go back and check it, and it's like, lo and behold, you're not doing so well at that test now. So, like a near point of convergence, say for instance, how well you can hold your eyes together. You might start with that and they're doing really, really well and you think this is great, and you go back and check it later and all of a sudden they can't hold their eyes together as well.
Absolutely, absolutely. And this is why a longer time spent with them gives you information as well. Like you say, you can look at how quickly they fatigue, how well they can hold attention, how restless they are getting. There's lots of information that you get out that you might miss if you're only seeing them for 5 minutes.
Yeah, so I suppose, we'll throw it back to the parents. Like, it's sort of, there is a lot of difference between screenings and comprehensive eye examinations, and which one would you prefer for your child to have before they start school? Well, leave it up to you guys to decide ultimately.
Yeah.
Now, I just wanted to quickly touch on do you want to quickly go through some of the things that I found in that study that I did? I'm very excited about it, so I can sort of touch on some of the interesting things.
Yeah, well, like I said, I actually implemented some of them, so share it.
Okay, so it's called the inclusion of parent and teacher questionnaires and visual perceptual testing for school-based vision screenings. So, look, to be honest, we probably bit off a little bit more than we could chew with this particular study because we included a lot of things, and we sort of knew that obviously we couldn't include them all. So, so I'm an academic, but I gave it my best shot with this. We did 176 children between the ages of 5 and 9 who attended local schools of the Western Downs in Chinchilla and Dalby. And my sort of hypothesis, or what I was trying to test, was that through awareness of problems with eyes and behaviours, that teachers and parents might be well suited to identify which children actually have problems, vision-related learning problems. So that was the whole idea, to try and empower the teachers and the parents to back themselves when they feel they've got a problem and come in and see us.
Yeah.
So in addition to the traditional screening tests, we also added a few more, and we added these questionnaires. This is a really interesting statistic. I found that vision, in my opinion, and according to this particular reference, I'm sure it's yours too, is the most important sensory function for learning in the classroom. And our eye sends 430 times as many messages to our brain than our ears in any given sensory experience.
Wow, I didn't know that. Wow.
So, yeah, crazy. How important are the eyes?
It's the dominant sense, isn't it?
Yeah, definitely. So, current screenings have the visual acuity and the gross. So, if you think about current screenings having a visual acuity and a gross assessment of ocular alignment, or in this case, it's using the autorefractor, then you could expect about 40 to 50% of children with vision problems to be undiagnosed by this approach, compared to what they classify as the modified clinical technique. Now, the modified clinical technique is a more extensive battery of visual screening, which includes visual acuity, cover test, retinoscopy, and ophthalmoscopy. So this is where an optometrist or trained observer will go and have a look inside the eye as well.
Yeah.
Now, the limitations to having the modified clinic technique is that you need an optometrist or an ophthalmologist. Yeah. So as far as the screening is concerned, that's particularly difficult to do. And also, that particular technique, from my perspective, has a bit of limitation that didn't include any visual efficiency or perceptual tests as well. So yeah, I'll skip forward a bit here. Well, usually when I read these things, I just go straight to the conclusion discussion. So let's just do that.
I read every page.
Well, I wrote it, so I did read it as well. But So quickly going to I've got to recognise there's a few limitations to this study, and that is that the results of a relatively small sample size, and we had less people that actually responded to the questionnaire. But we would definitely recommend that the studies involving school screenings use larger sample size for the next time. So that's the first thing I wanted to mention. And look, probably the most important finding from this, and I'm really excited to share this, is that the findings from the teachers' survey, the most important finding from the teachers' survey was that there was a relationship between teachers' assessment of reading level. So I sort of said to the teachers, what's your assessment of little Johnny's reading level? And a majority of the screening test results. So the teachers knew when the kids were going to have a problem. And so this indicates that teachers have an inbuilt intuition for assessing reading levels, but also for problems of vision as well.
I agree.
Yeah. So, like, if you're at all worried about your child, just ask your teacher. Like, they're going to tell you, and listen to what they say.
That's right. I agree.
So, yeah, definitely. If a teacher mentions something, potential benefit for referral treatment from an optometrist, potential pediatric ophthalmologist if you prefer, but I think optometrists are pretty good at handling these things.
Yeah. Yeah.
So some conclusions. Our suggested protocol for future school-based screenings would include monocular and binocular distance acuity, Hyperopia Test, Randot stare acuity, and the Jordan left-right awareness test. So I'll just quickly step you through those. So visual acuity is what they're doing already. The Hyperopia test is a test where we assess just how long-sighted people are. It's a great test. It sort of alludes to what we talked about with the binocular blurback. But basically, you put these glasses that are overpowered in front of the person's eyes and ask them and see if they can read through them. And if they can, they've got a amount of hyperopia, which you can debate is clinically significant. But if it is, then so we use the plus 150 level. Randot stare acuity. So you talked about how important that is. So I agree. That was super critical.
Yeah.
And the final one is the Jordan left-right awareness test. What are your thoughts about that test, Sarah?
Yeah, so really, really interesting test. And I think that a lot of people will think, why is optometry interested in whether I know my left and right? It seems like a really big leap, but it's to do with, as you keep talking about development, like being a block tower. And this, you mentioned earlier, do you know where your left and right are? This sense of, can I organize it in my own body first before I can organize myself on a page? This is a test that helps to look at, can you do it on yourself first before you put it on a page? And it requires the visual part of the brain to be able to do that. So it's not so much that eyeball test, it's that brain test. And I think it's a fun test to do. It's a really easy test to do. It's easy to score. It's a good one.
And it gives you an assessment of how the number of errors that you made and also the number of things that you did correctly. And so you can look at those and compare them as well. So it also it has that extra element of taking into consideration problems with concentration as well.
Yes, that's right. That's right. So you get a lot of information from a really simple test.
So that's what I would include in a school screening for next time if I was had my way.
The next time you do a research project.
Yeah, exactly.
Yeah.
So look, let's wrap up and do some thank yous. I want to thank Pauline Lambert first. So she was a French exchange optometry student that actually helped me with that study, and she put in all the hard work. So hats off to Pauline. Yeah. I want to thank you again, Sarah, because you're putting up with me doing these lives, and I think we're covering some good information here. So it's definitely valuable.
Pleasure. It's a pleasure.
Anybody that's watching this, look.
Yes.
Please, thanks for watching, and if you've got any questions or comments about it, then please let us know.
Yes.
So we did actually have a plan to do one more of these, and this is a 3 in our series of the Back to School, and the next one we want to talk about is what happens if your child is found to have a vision problem. So talking specifically about the evidence-based interventions that behavioural optometrists will usually provide in those situations when we've found a problem.
Yeah, excellent. Yeah, that sounds great. Keen to come back and chat.
Looking forward to it.
Yeah, lovely. Cool. Thanks, Tom.
All right, Sarah. Signing off. See you later.
See you next time. Bye.